maybe. It increases fetal hemoglobin. You know that? No, no, it is not the side effect. It is the mechanism. Yes. Okay, now management of sickle cell anemia. Management is vaccination, like vaccination against the shine, like Streptococcus pneumoniae, Haemophilus influenzae, like capsulated organism, penicillin up to age 5, folic acid supplementation, and hydroxyurea for patient with recurrent vaso-occlusive crisis. And for acute pain crisis, in acute pain crisis, hydration, analgesia, with or without transfusion. The hallmark of sickle cell disease is recurrent acute painful episodes, recurrent acute painful episodes due to vaso-occlusion. Acute management consists of hydration and analgesia with NSAIDs and opioids. Hydroxyurea is indicated in patients with frequent pain crisis and a history of acute chest syndrome and severe symptomatic anemia. The major benefit of hydroxyurea is to increase fetal hemoglobin. Sickled hemoglobin is therefore proportionally decreased, resulting in reduced polymerization of the RBC and fewer episodes of vaso-occlusion. Hydroxyurea also decreases the risk of acute chest syndrome and the need for blood transfusion. The primary dose limiting side effect of hydroxyurea is myelosuppression, neutropenia, anemia, thrombocytopenia, but otherwise relatively safe. Very low. Is probably it is articarial. Like in articarial and anaphylaxis, you have just given the diphenhydramine, antihistamine, and it improved. And if there is after giving like diphenhydramine, first generation antihistamine, if it does not improve, if it is anaphylaxis, it will not gonna improve. In anaphylaxis, there may be like, yes, after giving, yes. Yes, yes. Transfusion reaction, anaphylactic and urticarial. Anaphylactic is seconds to minutes, and urticarial is within hours. Anaphylactic is anti-IgA antibody in IgA deficient patient against donor blood IgA, and urticarial is preformed recipient IgE antibodies. Preformed recipient IgE antibody against soluble allergen in donated plasma. Anaphylactic is respiratory distress, wheezes, angioedema, hypotension, hives, and urticarial is hives and itching. Anaphylactic is immediate cessation of the transfusion, epinephrine, antihistamine, oxygen, blood, oxygen, fluid, and vasopressor. Urticarial is immediate cessation of the transfusion, antihistamine, resume transfusion if patient is otherwise asymptomatic. These hemodynamically stable patients developed isolated urticaria during a transfusion, which is consistent with an urticarial transfusion reaction. Urticarial transfusion reactions are common and typically mild. Pathogenesis involves histamine release due to preformed recipient IgE antibodies reacting against the soluble allergen in a donated plasma, or vice versa, donor IgE recipient allergen. Symptoms are limited to hives and itching, and develop hours after transfusion initiation. In contrast, hives due to anaphylaxis typically occur within minutes, or transfusion initiation develops in conjunction with wheezing, angioedema, and or hypertension. Management of urticarial transfusion reaction includes immediate cessation of the transfusion and administration of diphenhydramine if urticaria is extensive. Diagnosis is confirmed if symptoms improves and no signs of anaphylaxis develop. The transfusion can be resumed without additional evaluation. Okay. Yes. Transfusion transmitted bacterial infection (TTBI) is an uncommon severe complication of the transfusion that presents with fever, chills, and hypotension from a contaminated blood product, most commonly platelets. Culture should be obtained from the recipient. Culture should be obtained from the recipient as well as from the transfused product to identify the pathogen and potential source of infection, respectively. This patient has no symptoms of transfusion transmitted bacterial infection, and therefore testing is not warranted. Um, okay, it's due to blood. This patient is experiencing paresthesia. This patient is experiencing paresthesia due to hypocalcemia. He has had significant blood loss as a result of his injuries and has received packed red blood cell as a part of resuscitation effort. As a part of our resuscitation effort, prior to storage, whole blood or for transfusion is generally mixed with solution containing citrate anticoagulation. Citrate anticoagulation. Packed cells derived from these whole blood collection also contain citrate. Infused citrate can chelate serum calcium, causing hypocalcemia. This is most likely after massive transfusion of the equivalent of more than one blood volume over 24 hours. Yes, rule of formation. You have found the rule of formation. You have found hypercalcemia. Creatinine is slightly higher, not that high, but and there is a history of fatigue and age is more than 50. What's your thought? There is anemia. There is not bone pain like fatigue. There is hypercalcemia. Yes. Okay, multiple myeloma is a plasma cell neoplasm that often presents with constitutional symptom, weight loss, fatigue, bone pain. Multiple myeloma should be suspected in elderly patient with lab findings, hypercalcemia, normocytic normochromic anemia, renal insufficiency, and a protein gap. Like, is it gamma gap? Total protein minus albumin if it is more than 4. Okay, it is gamma gap is high. Protein gap or gamma gap. Protein gap indicates elevated non-albumin. A protein gap elevates non-albumin protein in the serum. It may be seen in polyclonal gammopathies or excessive monoclonal protein. Multiple myeloma, Waldenstrom macroglobulin serum protein electrophoresis can determine if a protein gap is caused by monoclonal or polyclonal source. If multiple myeloma protein in multiple myeloma, serum protein electrophoresis typically shows a monoclonal spike. Diagnosis is then confirmed by bone marrow biopsy. More than 20% of the clonal plasma cell. These patients mm, These patients' peripheral blood smear show rouleau formation, stacking of the red blood cell like coils, and the finding is elevated serum protein. Okay. Phenytoin causes gum hyperplasia. Okay, this patient has a history of seizure. Is treated with phenytoin, an anti-epileptic. Several common adverse effects, including folate acid deficiency and gingival overgrowth or hyperplasia. Phenytoin impairs folic acid absorption in the jejunum. Phenytoin impairs folic acid absorption in the jejunum, which often results in folic acid deficiency over weeks or months because folate tetrahydrofolate is required for purine or thymidine synthesis. Deficiency impairs DNA synthesis, particularly in cells that undergo rapid turnover, hematologic cells. These often leads to megaloblastic anemia, macrocytosis, hyperpigmented neutrophil, gingival overgrowth or hyperplasia. Gingival overgrowth or hyperplasia. Phenytoin has several effects on the gingival mucosa, but is thought to reduce folic acid use in the extracellular matrix of the gums, leading to impaired collagenase activity and subsequent buildup of gingival matrix. These adverse effects can usually be prevented on oral folic acid supplementation because phenytoin also disrupts bone and mineral metabolism. Calcium and vitamin D supplementation are usually administered. Other medication that commonly causes megaloblastic anemia include methotrexate, trimethoprim, pyrimethamine. Due to disruption in dihydrofolate reductase, the enzyme that mediates tetrahydrofolate production. Got it? If MCSC is high, you don't need to read anything. Okay, it's hereditary spherocytosis. Do you want me to read the explanation or we can move next? Okay. Is it some sort of hematoma? Sorry? Okay. Rectus sheath hematoma, abdominal trauma, forceful abdominal contraction, coughing, anticoagulation, older age, female sex. Clinical feature is acute onset abdominal pain with palpable abdominal mass, blood loss, anemia, leukocytosis with or without nausea, vomiting, fever. Hemodynamically stable patient. There is serial monitoring of the CBC, reversible anticoagulation, and transfuse blood products when appropriate. Unstable angiography with or without embolization, and surgical ligation. This patient, this patient taking apixaban, these patients taking apixaban develop acute abdominal pain associated with palpable abdominal mass, anemia, and the development of rectus sheath hematoma. Rectus sheath hematoma occurs due to rupture of inferior epigastric artery, which supplies blood to the lower aspect of the rectus abdominis muscle. The rectus sheath, which contains this muscle, does not extend posteriorly, below the arcuate line. Therefore, okay, where I am, okay, arcuate line. Therefore, bleeding below the line, lower aspect of the rectus abdominis muscle is relatively uncontained and uncontained and can result in significant hemorrhage with hematoma formation. Rectus sheath hematoma is often seen with blunt trauma or forceful abdominal contraction, severe coughing, particularly in patients receiving anticoagulation therapy. Manifestations include acute abdominal pain, often associated with rebound or guarding, and a palpable abdominal wall mass. The mass does not cross the midline and does not change with movement of the lower extremities. Fothergill sign. Nausea, vomiting, fever may also occur. Lab findings usually include anemia, leukocytosis, likely due to inflammation. Abdominal CT confirms the diagnosis. Hemodynamically stable patients are usually managed conservatively. Um, that is serial monitoring of the CVC, reversible of anticoagulation when appropriate. However, those with significant bleeding or hemodynamic instability, shock may occur, or angiography with immobilization or surgery. Next. Yes. It's, no, no, I choose the E. Uh, I remember, but the most important is like schistocyte, DICTTP has help. Schistocyte, helmet cell, fragmented cell. Okay, okay. Target cell, you know the target cell is halt, hemolysis, uh, liver hemolysis, sorry, hemoglobin C disease, asplenia, liver disease, and thalassemia. HALT for target cell. Bite cell G6PD. Okay, okay. I am just going through that box. Okay, you haven't. Okay. Can you see my screen now? I know it's a lot, but you can remember the important one. Okay. Yes. HALT is hemoglobin C disease, asplenia, liver disease, and thalassemia. Hemoglobin C disease, asplenia, liver disease, and thalassemia for target cell. Okay. So in this box, like this one is very important. Like this area, like Heinz ketchup, like Heinz body, G6PD deficiency. Okay. And in explanation, these two part is another important. Like Heinz body is denatured and precipitated hemoglobin, like it contains iron. So Heinz body actually contains iron. If you look at the picture, this is the picture of the Heinz body and it contains iron. And basophilic stippling, like it also oh, okay, look at the Howell-Jolly body, the B. If there is functional hyposplenia like sickle cell disease, or if there is asplenia, you get this basophilic nuclear remnant, but it do not contain the iron. Got my point? So difference between this H and this H, like Howell-Jolly body, it does not contain iron. There is basophilic nuclear remnant. This one, basophilic nuclear remnant, and the Heinz body is G6PD deficiency. It contains iron. Got it? And the in the bone marrow iron granule, like sideroblastic anemia, like lead poisoning, myelodysplastic syndrome. In here, there is perinuclear mitochondria with excess iron, and it requires Prussian blue to stain to be visualized. And you don't need to remember this tough thing. And in here, you need to remember the halt. The sickle cell, and sometimes these things comes like degmasite bite cell for G6PD deficiency, and that hereditary spherocytosis has spherocytic type of cell. Okay, and in here there are some pictures. I know it's a lot, and this is the helmet cell. It has another new name. Where triangular cell. Where is the Okay, it is not written here. It is written in the question, uworld question. Okay. Okay. So Howell-Jolly body in the picture, round, dark, blue inclusion in the RBC. Round, dark, blue inclusion in the RBC, and Howell-Jolly body does not contain iron. Okay. This patient, single, round, blue inclusion within the RBC on peripheral smear contain Howell-Jolly bodies. These bodies contain RBC nuclear remnant. These bodies are retained RBC nuclear remnant that are typically removed by spleen. The presence of Howell-Jolly body usually indicates either physical absence of the spleen asplenia due to congenital absence, or surgical removal of the functional hyposplenism due to splenic autoinfarction, sickle cell disease, infiltrative disorder of the spleen, sarcoidosis, and splenic congestion thrombosis. Both asplenia and functional hyposplenism increase the risk of sepsis because the spleen is normally responsible for clearing bacteria, particularly encapsulated organisms. However, splenectomy may be indicated in case of chronic hemolysis. Yes, in G6PD deficiency, hemoglobin becomes oxidized and precipitates into insoluble Hinge body. Peripheral smear show bite cell and Hinge body appear as peripheral blue inclusion with special staining, crystal violet, not with right staining as in this patient. And the precipitation of the ribosomal nucleic precipitation of ribosomal ribonucleic acid is seen in patients with lead poisoning in contrast to single blue peripherally located inclusion. Characteristics of Hall-Jolly body. Basophilic stippling appears as multiple scattered blue granules within the RBC cytoplasm. So this patient with Hodgkin lymphoma was treated with chemotherapy and radiation therapy, which cures most cases. However, patients who undergo treatment for Hodgkin lymphoma are at increased risk for death compared to age-massed population due to following Hodgkin lymphoma relapse or recurrence, the leading cause of death for the first 8 to 10 years after treatment of Hodgkin lymphoma relapse. Okay, sorry. Hodgkin lymphoma relapse, the leading cause of death for the first 8 to 10 years after treatment is Hodgkin lymphoma relapse. Relapse primarily occur in first 2 years, but risk remains mildly limited for life. Second malignancy, the leading cause of death more than 8 to 10 years after treatment is second malignancy, and the risk increases with time. Breast and lung malignancies are common due to their proximity to the mediastinum. Breast and lung malignancy are common due to proximity to the mediastinum, which is often irradiated as a part of Hodgkin lymphoma treatment. Hematologic malignancy, non-Hodgkin lymphoma can hematologic malignancy can also occur due to damage to the hematologic stem cell for ankylating chemotherapy. Milder chemotherapy regimen, that is doxorubicin, bleomycin, vinblastine, dacarbazine are associated with less risk of second hematologic malignancy. Cardiovascular disease, the leading cause of death not due to malignancy is cardiovascular disease. Most cardiovascular complications arise more than 10 years after treatment and are due to chemotherapy or radiation therapy related damage to the heart muscle, valves, and vasculature. Patients who undergo Patients who undergo treatment for Hodgkin lymphoma typically receive Patients who undergo treatment for Hodgkin lymphoma typically receive intensive screening for Hodgkin lymphoma relapse, usually after treatment, and for malignancy and cardiovascular disease as time progresses more than 5 years after treatment. Modifiable risk factors for cancer, quitting smoking, and heart disease control of hypertension and hyperlipidemia should be addressed to lessen the risk of early death for these conditions. Okay. I don't I don't know. Oh no. Um, brownish skin pigmentation. Brownish pigmentation. Brownish. Sorry, is it a bronze brownish? Sorry, maybe erectile dysfunction. There is a brownish skin pigmentation like bronze diabetes. It, it may be hepatocellular. It is hepatocellular. Yes, bronze like hereditary hepatitis can cause diabetes, not pancreatic cancer. Cannot. Maybe this patient's presentation is most consistent with hereditary hemochromatosis, the increased total body. This this patient's presentation is most consistent with hereditary hemochromatosis. The increased total body iron leads to deposition in various organs like liver, pancreas, resulting in multi-system organ damage. Disease progression typically requires decades of increased iron deposition. Patients tend to present in their 30s to 50s, with women presenting later due to therapeutic iron loss through menstruation. Most patients with hereditary hemochromatosis are diagnosed early in the disease. due to elevated liver enzyme or routine lab studies. However, continued iron deposition cause hepatic fibrosis and cirrhosis, skin pigmentation, sun-exposed areas, scars, genitalia, diabetes mellitus, bones diabetes, arthropathy, and hypogonadism, diminished libido, erectile dysfunction. Patients with hereditary hemochromatosis have an approximate 20-fold increase in HCC, accounting for 45% of death in hereditary hemochromatosis patients. The initial evaluation of HH commonly shows elevated iron status. Diagnosis can be confirmed by genetic analysis of the HFE mutation. Serial phlebotomy to deplete excess iron store can significantly reduce the risk of cirrhosis and hepatocellular carcinoma. Next. Yes. Pancreatic cancer can be associated with chronic pancreatitis and certain genetic syndrome, Peutz-Jeghers syndrome, but not HH. Patients with genetic disorders such as xeroderma pigmentosum and albinism are increased risk for skin cancer. HH does not confer increased risk. HH does not confer increased risk. Okay. Is it polycythemia? Hematocrit is very high. It does not. Apart from this, is anything fits? Uh, there is there is something like glycogen storage. Is there any glycogen storage? There is hypoglycemia also. I don't know. Maybe polycythemia because it fits liver problem. Yes, true. Hematocrit more than 65% in term infant causes increased erythropoiesis from intrauterine hypoxia, maternal diabetes, hypertension, or smoking, intrauterine growth restriction, erythrocyte transfusion, delayed cord clamping, twin transfusion, genetic metabolic disease, hypothyroidism, hyperthyroidism, genetic trisomy 13, 18, 21. Clinical presentation asymptomatic, most common ruddy skin, hypoglycemia, hyperbilirubinemia, respiratory distress, cyanosis, apnea, irritability, jitteriness, abdominal distension, IV fluid, glucose, partial exchange transfusion. Polycythemia is defined as hematocrit level more than 65%, more than 2 standard deviation above the mean. In term neonate causes include excessive transfusion, that is delayed umbilical cord clumping, twin transfusion syndrome, intrauterine hypoxia, poor placentation due to maternal diabetes or hypertension, smoking, or genetic condition trisomy 21. In this patient, maternal preeclampsia causes placental dysfunction resulting in intrauterine hypoxia and growth restriction. Other than ruddy or plethoric appearance, most neonates with polycythemia are asymptomatic as the hematocrit level rises due to post-birth fluid shifts. The increased blood viscosity may cause the increased blood viscosity may cause decreased blood flow to the organ. Common consequences include lethargy, irritability, jitteriness. Severe symptoms include respiratory symptoms, tachypnea, poor feeling, cyanosis. The increased red blood cell mass can lead to hypoglycemia and hypocalcemia. Hypoglycemia and hypocalcemia due to increased cellular uptake. Treatment of polycythemia is hydration by oral feed or glucose containing parenteral fluid. Yes, transient tachypnea of the newborn is a common cause of respiratory distress. In term neonate, chest X-ray will show increased pulmonary vascular markings. Chest X-ray will show increased pulmonary vascular markings or fluid in the fissures. In contrast, infants with polycythemia have normal X-ray because the total fluid volume in the lungs is normal. Okay. Sorry, maybe less than 30,000 and more than 30,000. More than 30,000 observation and less than 30,000 glucocorticoid IVIG. Okay, observation, isn't it? This type of question is very tough. Uh, like ITP. Okay. uh, Immune thrombocytopenia, etiologies, platelet autoantibody, and preceding viral infection. And what are the virus? Do you know? HIV and hepatitis C. It is
Okay.
not written here. It is written in the inner circle. Okay. Petechiae ecchymosis and mucosal bleeding, epistaxis, hematuria. There is isolated thrombocytopenia less than 1 lakh. Few platelets on peripheral smear. Children observe if cutaneous symptoms only. Glucocorticoid, IVIG, or anti-D. Uh, Glucocorticoid, IVIG, or anti-D if bleeding. Adults, adults observation, adults observation if cutaneous symptoms and platelets more than 30,000, and glucocorticoid IVIG and anti-D if bleeding or platelet less than 30,000. Immune thrombocytopenia, most immune thrombocytopenia in most common in children aged 2 to 5, characterized by abnormally low platelet less than 1 lakh that results in increased propensity for bruising and bleeding. In ITP, autoantibodies are directed against platelet membrane antigen, leading to destruction of antibody-platelet complex in the spleen. ITP is usually preceded by a viral infection, as in this case, when presence with petechiae and purpura. In severe cases, patients may experience mucosal bleeding, epistaxis, hematuria, GI bleeding. Lab studies show isolated thrombocytopenia and a few variably sized normal to large platelets may be present on peripheral smear due to increased platelet turnover. Observation alone is recommended for children, or observation alone is recommended for children with only observation alone is recommended for children with only cutaneous symptoms, petechiae, regardless of platelet count. The course is usually self-limited with spontaneous recovery within 3 months. Glucocorticoid, anti-D immunoglobulin if Rh positive and Coombs negative, or IVIG is the first line treatment in children with mucosal bleeding. Okay.
Okay. Next. When one woman comes to the hematology, since we history of cases, the patient this is for the normal autopsy.
Okay. This patient has a large intermediastinal mass that is coughing This patient has anterior mediastinal mass that is causing cough, shortness of breath, and postural wheezing due to mass effect compression of other mediastinal structure, including the trachea. The differential diagnosis of the anterior mediastinal masses include 40, thymoma, terrible lymphoma, teratoma, germ cell tumor, and thyroid neoplasm. Hormones levels, when serum hormone levels, when serum hormone levels of the alpha fetoprotein and beta HCG elevated, a malignant GCT is unlikely. Malignant giant cell tumor occur predominantly in young men, can usually be distinguished by difference in serum hormone levels. Seminoma, which are common, then non-seminomatous giant cell tumor may cause elevated serum beta HCG in a minority of the cases, but alpha fetoprotein is always normal. Non-seminomatous giant cell tumor, which include yolk sac tumor, choriocarcinoma, embryonal carcinoma, and mixed giant cell tumor that contain a mixture of giant cell types, causes an elevated alpha fetoprotein and or beta HCG in the majority of the patient. In contrast, benign teratoma of the mediastinum typically do not cause elevation of either alpha fetoprotein or beta HCG. They can also be distinguished from giant cell tumor on imaging uh, by presence of fat, bone, or fluid. Biopsy is typically performed to confirm the diagnosis prior to treatment. In addition, testicular ultrasound is performed to determine whether a primary testicular tumor is present, because management and prognosis differ from differ among primary mediastinal and metastatic giant cell tumor. Okay.
Okay. 56-year-old man with a recent diagnosis of cirrhosis. What's the prognosis for him? Is the most likely cause of this patient decrease? Decrease?
Decrease. Oxygen saturation is 99%.
Hmm. But it's 99. How did it decrease? It didn't decrease. So is this before the surgery or after?
Hyperventilation. Alveolar arterial gradient. Sorry. Now, during the procedure, patient's oxygen saturation is 85%, and results of urgent lab are as mm, is there a altered level of hemoglobin? That's why oxygen saturation is decreased. Altered state, yes. Hem Hemoglobin does not bind with the. I think that. Wait. He has got the topical anesthesia, benzocaine. That actually changed the. That actually causes the change of the hemoglobin bind with the oxygen. All that I am trying to mean. Benzocaine. It is local anesthetic. Uh, benzocaine. Like methemoglobinemia. Other does not fit what you are choosing. It's the reason of this topical anesthetic, benzocaine. Okay. This patient has new onset hypoxemia by pulse oximetry. New onset hypoxemia by pulse oximetry during an endoscopic procedure with significant difference between oxygen saturation value estimated on ABG analysis that obtained on pulse oximetry, large oxygen saturation gap. He likely has acquired methemoglobinemia due to anesthetic use. Some medication, topical anesthetic, benzocaine, taps on nitrate in patient the iron causes the iron component of the hemoglobin to be oxidized and thereby forming methemoglobin which cannot bind with the oxygen. The remaining normal hemoglobin has an increased affinity. Remaining normal hemoglobin has an increased affinity for oxygen, resulting in less oxygen delivery to the tissue. Because methemoglobin may absorb light at distinct wavelength, pulse oximetry commonly is 85% as seen in this patient. In parallel, blood gas analysis returns a falsely elevated result of oxygen saturation 99% as it provides an estimated as it based on PaO2, not effective hemoglobin oxygen binding. This inaccurate reading creates a large oxygen saturation gap. Cyanosis can occur when methemoglobinemia comprises more than 10% of the hemoglobin, but hypoxemia symptoms, headache, lethargy occur when levels occur only when levels suppress 20%. At more than 50% risk of severe symptom, altered mental status, respiratory depression, and death. Treatment involves discontinuing the causative agent and administering methylene blue, which helps to reduce iron to its normal state. Yes. Hepatopul- Hepatopulmonary syndrome from arteriovenous shunting. Hepatopulmonary syndrome from AV shunting in the lungs can occur after Uh, after year occur after years of liver disease. Patients uh, patients frequently exhibit platypnea, platypnea-induced dyspnea with upright position, orthodoxia, hypoxia in upright position. This syndrome would not explain this patient's large oxygen saturation gap. Is it like Hodgkin lymphoma? Okay. This patient with hilar and mediastinal lymphadenopathy B symptoms, fever, weight loss, likely has Hodgkin lymphoma, a lymphoid neoplasm with peak incidence in early adulthood. So, and in those more than 60, most cases come to clinical attention due to painless lymphadenopathy in the cervical or supraclavicular chains. After chest radiographs show a mediastinal mass, B symptoms are present in approximately 40% of these cases. Patient is generally made by excisional lymph node biopsy uh, that those with no clear evidence peripheral lymphadenopathy on physical examination usually undergo imaging to identify potential biopsy site. PET scan with 11 fluorodeoxyglucose, an analog of glucose, is often imaging test of choice. Neoplastic supraclavicular or mediastinal lymph node in this patient have high metabolic rate and readily take off radio tracer on PET scan. However, radio tracer also pulls in healthy organs have high glucose requirement. Radio tracer also pulls healthy organ with high glucose requirements such as brain, kidney, liver. An excretion of the radio tracer also leads to enhancement through the urinary collecting system. I do not get the last point. Like radio tracer also pulls in healthy organ high glucose requirements. So radio tracer like PET CT we are using 11 fluorodeoxyglucose, isn't it? So it is taken by the neoplastic cell. Neoplastic cell need glucose, so they need high metabolic. They need glucose. They are taking the radio tracer. So other like brain, kidney, liver, they are also taking the radio tracer. So how will you differentiate? How will we differentiate? Like is it lymphoma or is it uh, in is it so Okay. 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 Have you done your breakfast?
No,
Okay. Then habit.